Hello and welcome to the Big Picture podcast. I'm Melissa Moodley, Head of Healthcare at Ipsos in the UK. And today we're tackling an important but also very complex topic, which is all about navigating obesity care in the primary setting. It's a subject which is close to many people's hearts, and we'll be covering a wide range of topics, all the way from how it affects the individual to also the wider systemic challenges. And I'm thrilled today to have Anthony Cunliffe, who is a GP, but also the Macmillan National Lead Medical Advisor and Clinical Advisor in London as well. Anthony comes with a wealth of experience in community health, is a strong advocate for health equity. So welcome, Anthony. Great to have you.
Good to be here.
So to kick things off, when we talk about obesity in the clinical setting, there's so much. It's so much more than just a number on a scale or talking about BMI. It's about the person's entire health journey. In your experience and when you're talking to patients, what are some of the biggest misconceptions you see in those discussions around obesity?
Yeah, I'm not sure whether they're misconceptions as much as misunderstandings. And it's not just the people that we see, it's the healthcare professionals as well that perhaps have misunderstandings about obesity, and maybe not even just misunderstandings. People maybe just not giving it the thought that it deserves, really. So, if people are activated enough and feel able to come to see us to discuss weight loss or concerns about their weight, there are various challenges for the healthcare professional in the primary care setting at that moment. One is just time. So we don't, as a GP at least, we don't have a lot of time for each patient. We're not allocated a lot of time. If they'd just come in to discuss that one thing, then you'd hope we would, give it the dedication it deserves. But often people will come in with, another problem and then the weight will come up. And that can be a challenge. And I think that contributes to perhaps some of the people feeling a little bit dismissed by the healthcare professional when they bring up their weight. Kind of misconceptions, misunderstandings. It's not a complete misconception because unfortunately obesity does have a lot of modifiable risk factors that come into play. So, obviously diet, physical activity, etc. But it isn't that simple. There are genetic factors at play, certainly for some people. Sometimes we might even be adding to the problem by the medication we're prescribing, and I suspect that's something that's rarely thought about when somebody comes in with concerns about the weight, unless they're, again, activated enough to identify that might be a problem. But also we're living in an environment where healthy lifestyle isn't particularly supported, encouraged in many different ways. So I think a lot of the time, unfortunately, it's purely seen through the lens of diet and physical activity, and it's just not quite that simple, even though they are obviously big players in people who are struggling with the weight.
So clearly, Anthony, it's a multi-layered, complex issue. There are challenges for healthcare professionals themselves. And I thought it's quite interesting what you said about patients and just even making the step to come and discuss and talk about it. And this leads us into the topic of health equity and around access. What do you think can be done to, create that kind of space, make it easier for people to come and have this discussion?
Well, I think there are various kind of angles that we might want to discuss there. One, and it's an issue with all areas of health inequity, is just trust. People will probably, whether it's in the private life or often engaging with healthcare, will have either been dismissed or received what they, probably rightly perceived as prejudice around their weight. And if that happens once, then for that individual to be brave enough to represent and highlight their own concerns about the weight, it's just a big hurdle. It's a big hurdle anyway. But if they've had a bad experience, then they might just never do it again, or they might just avoid situations where it might come up. And so I think trust is a big issue, and we've all got a part to play there. Certainly healthcare professionals have got a big part to play to make sure that we aren't demonstrating, weight bias, that we are making sure that we're consulting in a completely non-judgmental way. And I think, it's an important thing for healthcare professionals because it's not just about obesity. This is, so many people who, whether they're from a marginalized population, whether they feel stigmatized by a health choice. We see it with smoking all the time. It's really easy for people not to come and ask for help and perhaps actively avoid that. And that's just something that we as healthcare professionals need to bear in mind all the time, that every single contact counts. And unless we're being non-judgmental, being completely open, giving people at least the opportunity to discuss these things, whether it's with us as a GP or with the many other amazing healthcare workers we have within our primary care networks now, it's just such a responsibility and we need to keep it in mind all the time. So I think trust is a big issue.
And that's quite interesting as well, because if we stick on the topic of health equity, you talked about, every touch point matters, but we also know quite a lot of people are not even accessing maybe any touch point and getting to any of these practitioners. What do you think can be done there to really get to these underserved communities?
So I think there's a couple of angles. One is we have to address, I'm going to use the word, I don't know if it's the right word, but fatalism. And we see this with a lot of issues in primary care that are considered or maybe misconsidered, I don't know, in some situations to be all about a lifestyle factor. And we definitely see it within smoking. So we've got the lung cancer screening program being rolled out across the UK at the moment. But unfortunately, although we're reaching a lot of people and it's seen some absolutely fantastic results around earlier stage diagnosis of lung cancer, what we also know is we're probably not reaching those at most high risk. And there's an element of fatalism there, but also an element of blame. So blame and shame. So people, because they're being targeted because they've been an ever smoker. So they're actually being targeted because of a lifestyle choice they've made. And that can actually have a negative effect on getting someone to engage because they're worried that they'll face prejudice, that they're worried that the whole thing will be about getting them to stop smoking. Now, it will be an element, but that's not the main driver of the program. And I think it's the same with obesity, really. People might get to a point, especially if we're talking people who are, significantly overweight, they might have lost hope, they might have lost trust that, the healthcare professionals or primary care professionals will care. And so I think we definitely have to address that. And then obviously there's an access issue as well. So if people are struggling to get in to see a GP, even when they're feeling very unwell, and we're not here to talk about access to primary care, of course, but if we open the doors more easily with some of these other healthcare professionals, now we have to make the people that we look after aware that these professionals are even there and that they can help with things like losing weight. So we've got a bit of a job to do in kind of promoting these amazing colleagues that I work with that can help in these situations, but people need to be aware of them to be able to access them. And I think that's a job we've got to do, and then make that door easy. So make it easier for an individual to make an appointment with a social prescriber because they want to discuss, what support is available to lose weight. So we've got a lot of kind of promotion and awareness to address there.
No, absolutely. And it also sounds like the promotion and awareness needs to happen at different levels as well. So firstly, around making people knowledgeable about the different kind of touch points that they can have. Like you said, the nutritionists, the wellness coaches, are people actually aware of that? And you touched on cancer care. And previously you talked about smoking cessation as well. With your quite varied experience, what do you think we can learn from the experiences with cancer care, for example, translating some of that to obesity care?
Yeah. So I'm very pleased that I feel in this country we have excellent cancer care. And obviously when somebody's diagnosed with cancer, it could be the most significant moment of their life. And for most individuals, and of course not everybody, but for a lot of people, from that point, they will receive a lot of support. And that support will, maybe last for quite a long time for some people because they're going through lengthy cancer treatment. It might mean multiple contacts with a doctor. It might mean multiple contacts with a a named individual, whether that's your specialist nurse or a navigator, you might get signposted to prehabilitation services and rehabilitation services after you've had your treatment. And people might decide at that point to also discuss lifestyle factors with you because of the ongoing risks, certainly after being treated for cancer, of recurrence, etc., or even a second primary. So we see this and I'm going to caveat, not everybody does have a great experience, of course, but we see this wraparound service over a fairly long timeline to really try and support that individual through, understandably, an incredibly difficult time in their life for both those and the close ones around them. And I almost feel like our approach to obesity is almost the other end of the spectrum. We might see someone, we might say, yeah, you need to lose weight. Yeah, take in less calories than you're burning. You need to be more physically active, or maybe come and see one of our social prescribers. And that might be the experience that most people get when they see a GP about it. And so if they're activated enough, people might push back on that and say, no, yeah, but what's available? What is there any medication you can prescribe me, etc. But a lot of individuals might just be deflated at that point, leave, and not feel engaged enough to follow the advice, a very brief advice perhaps that they've received from a primary care professional. Whereas if that moment triggered essentially a treatment process, which would involve physical support, identifying of potentially other long-term conditions, nutritional advice, physical activity advice, physical activity programs, if that's what somebody could engage with, or weight loss programs, if that's what somebody could engage with, and then really follow up as well. It's that follow up, because often we'll signpost somebody to someone, and then we might, and I would say a lot of our new professionals, like our social prescribers, are much better at this than us GPs. But we might signpost somebody to a solution and we don't even check whether they've engaged. If they have engaged, has it achieved anything? But we should have all that follow up in place. Now, I am, as a GP and as a primary care professional, we are under the cosh. Capacity is tighter than it's ever been. So I understand why a lot of us, and I'll be guilty of this a lot of the time, so I'm not pointing fingers, I'm culpable as well, might not have that headspace to see that bigger picture. And again, it's not just our responsibility. We need those follow-up services in place, but they need to be commissioned by our local integrated care boards. And that pressure needs to come from higher up. It needs to be in our planning guidance so that we're compelled to have those services in place. But once they're in place, then we have to have the education and the support for primary care teams to be able to support the people we look after to engage with them.
So it sounds like there's lots we can learn from cancer care, translating the fragmented, maybe quite short-term thinking that we currently have in obesity care to a bit more long-term. I think the follow-up piece is also a very important aspect, to give people that attention.
Absolutely.
And ongoing touch points as well, because it is a challenging journey in a different way. It's important for the GP to really be trying to catch the important points in the conversation and making the patient then want to take that next step. But of course, it's not only the GP's responsibility. We know there are other practitioners as well. And we've been talking about the systemic challenges. And today is probably a good time for us to be talking with the 10-year plan just coming out. And there's a special focus on obesity. What's your first reaction to what's in the plan?
Well, they've called it a moonshot, which I think it's opposite. It is a very lofty ambition, what they're saying. And I think sometimes when things are so ambitious, you can almost think, well, it's never going to happen. So, and get a little bit despondent about it. But I think the fact that it's been called out, the fact that they're calling it a moonshot is highlighting what a big problem it is, and that it needs a lot of resource and impetus behind it, right from national level, from an environmental issues, from commercial issues, right down to kind of medical and healthcare issues. So I think it's encouraging. There's a lot in there that is outside of healthcare, so I don't necessarily completely understand how ambitious or how realistic it is, but it all also seems really sensible, and obviously trying to address the fact that a lot of people can't just afford healthy food. I mean, it's such a fundamental issue that it's great that it's called out. Obviously, we'll have to see the follow-up and what comes next. There are specifics in there around free school meals, etc., and trying to help people who are struggling with the cost of living. It isn't just about the finances. Obviously, there has to be more that goes with that, especially from a public health point of view. But I think let's be encouraged that it's called out, that it's got a fairly decent section in there in the long-term plan. And we've all got to get behind it, I guess.
And I think one of the interesting aspects is it talks about lifestyle, talks about, healthy food, moving more, but also about medication and increasing the access of weight loss medications to more people. What's your thoughts on that?
So we're in a funny time at the moment in primary care with these weight loss medications, because obviously they've been available for a little while, but not prescribed in primary care. And then very recently we can now prescribe them in primary care. But unfortunately, I think it's not clear through media, etc., that the restrictions are incredibly tight. So say in my practice, once we knew what all the conditions were of who we could prescribe to, in a practice of 8,000 people, we identified 5 people that met those criteria. So we can proactively reach out to them. That's great, and do that. But there'll be so many more people that approach us now because they know it's available as a primary care prescription. But then we're going to have really difficult conversations with those people because it's not available for us to prescribe for them. And then we've got the conversations about the other weight loss support we have. But unfortunately, if somebody has come hoping that they can prescribe the medication that they'll have seen people, whether it's in their lives or in the media, that have had really good impact from these weight loss medications, to then say to them, sorry, not available to you, but, I can signpost you to the gym. You know what I mean? It's not what they want to hear, or not what maybe they're expecting to hear. So I think we're going to have some really difficult conversations going forward. But we are seeing massive impacts of these weight loss medications on an individual. We do also have the challenge, though, that we do have to promote healthy lifestyle alongside that, because we know that even on the NHS now, you're only allowed to be prescribed it for a certain amount of time. And unfortunately, the evidence that we have shows that once it's stopped, a lot of people will put that weight back on. So unless during that time, we've spent a lot of time really educating and supporting people to address all the other things that can impact on weight gain. If things might change, the prescribing of these medications, or the limitations around them and how long we can prescribe them for will change as real world evidence becomes more prominent. But at the moment, we're not going to be able to prescribe them forever. And so it is just one solution among many, but at the moment, from a primary care perspective, it's a solution for a very, very tiny percentage of people.
So more clarity needs to come in terms of actually how do you make the broader access happen, and how to maybe also support GPs in some of this conversation and dealing with this increased demand.
I mean, absolutely, because prescribing processes, commissioning processes, they can be complex, and why would people understand it if they're not in the health and social care system? So unfortunately, a lot of that time, people just feel that we're refusing to prescribe something that can be prescribed, and potentially refusing to prescribe it through prejudice. And on the whole, none of those are the reasons we're not prescribing. It's just that we've got very strict criteria that we can prescribe for. And I guess what we need to see, and I think it will come as we get much more real world evidence from these medications, is a loosening up of those prescribing criteria. And I think we will see it. But at the moment, the restrictions are really strong now. Of course, people can go out and get it privately, and we know a lot of people are going out getting it privately. I've got no issue with that at all. But from an equity point of view, obviously that's a real challenge. And even those that can afford it and go and get it privately, still we find that they don't tell us. Again, and maybe that comes down to that prejudice element. And so if they don't tell us, we don't know they're on that medication, and we can't address things like interactions with the other medications they're on, or they might come in with feeling bloated and nauseated, and we could go down a road of investigating that one. Actually, it's probably the side effect of the injection that they're on. And so it's complex. We're at the very early stages of a road with these medications. I feel maybe naively optimistic about where we'll go with them, but we're yet to see.
And we have to see it play out, need to see that real world evidence.
Absolutely.
And then hopefully expanded access and easier access for individuals as well.
Absolutely, but always in conjunction with lifestyle education and
Absolutely.
support.
So I guess the challenge or the danger in a way could be that over-reliance on
Absolutely.
the medication. We're not thinking about the other aspects.
Yeah, I mean, absolutely. If people have tried for months or years for a lot of individuals to lose weight through dieting or through exercise, through both, and seen minimal results, and then they go on a medication and see fairly profound results, we've got to manage that kind of message that might give to that individual, that actually, why was I bothering with all that? Because this was the solution I needed. But it's not just about the weight loss, it's about all the other health benefits that come from lifestyle changes.
So another element of the wider kind of 10-year plan is around moving from sickness or more towards prevention.
Yeah.
And when we are talking a lot about obesity, we are not really talking about early prevention or kind of early intervention. For you, what would be a meaningful kind of steps towards earlier intervention?
I mean, we know that prevention is fundamental. And I don't mean just prevention of obesity. Prevention of disease is fundamental, and addressing risk factors like obesity are part of that prevention of disease. I think it's difficult when it comes to obesity because it starts very early in life, or it can start very early in life. And I remember going on some child protection training, because we have to do that as GPs, a good few years ago now, and I'm going to misremember the statistic, but I was surprised that if somebody was overweight, I think it was around the age of 2, then that was a strong predictor of a risk of developing adult obesity. And that really startled me. And I don't think we do a very good job as healthcare professionals, because how do you have that conversation with somebody who brings the child in for another, for a cough or a cold, and you think, oof, that child's overweight? How do you raise that conversation delicately and impactfully? It's just really difficult, but we need to, and it needs to be started at nurseries and certainly at primary school. We need to find ways of addressing, people, young children being overweight, but in a really supportive way, because that child might be overweight because the food that is available to them isn't perhaps the healthiest food, because that's the food that the family can afford, etc. And it's not as simple as that. Of course, there are lots of other reasons, but you've got to think about all those elements that might be contributing to that child being overweight for its age. But we probably need to get way bolder at addressing things at an early age. And similarly for adults who are starting to gain weight, how early do you have that conversation, that prevention conversation? Especially, how do you identify it as a healthcare professional? It might be an individual you've never seen before. So unless somebody's proactively flagging that they're putting on weight or that they're noticing changes in their weight, I think it's a real challenge. So a lot of it is public health. It's messaging out there about the risks of being overweight, but also we need to have the services and the support in place, because there's no point just flagging a problem if we don't have an accessible solution.
So it sounds like if we're talking about really meaningful early intervention, it goes even broader, into schools, into the education system, and also just thinking about where's the right moment, how to have those conversations, which sounds even more complex than the discussions that you have right now, or the potential stigma around some of the challenges people have.
I mean, absolutely. And healthcare probably isn't the solution to that. We need to work with education, public health, schools, to look collaboratively at how we can address a burgeoning problem that we see in the UK.
What do you think is really needed to prevent obesity? And do you think we can realistically prevent obesity?
Well, we've discussed that it's multifactorial. So I don't think we can prevent all obesity. If genetic factors are in play, psychological factors are in play, psychosocial factors are in play, it's going to be difficult to prevent completely. But if we are all able to see the bigger picture and see all the things that are in play that are leading to the obesity problem we have in the UK, then we can certainly significantly improve things. We've seen it with smoking, like the drop in smoking rates has been significant. We'd like it to, get even better, but we have seen very significant drops in smoking rates because of decisions that were made by the government, public health, etc. And I think if we can be bold enough when it comes to nutrition as well, and available nutrition for individuals, be bold enough with the messaging around it, and with being bold enough and understanding how to raise it with individuals. Also thinking about making physical activity much easier to access, especially in urban environments. I think we can make significant progress. But I think it's probably never been called out quite as much as it's been called out now, like smoking was, 10, 15 years ago. So maybe now's the time.
So this is a positive step that's come out of the plan, which gives hopefully some kind of new opportunities to make these improvements.
I would say so, absolutely. I mean, we need to see how it's going to be delivered, of course. But the fact that it is been highlighted and that there is, quite a significant focus in the plan on obesity, I think let's be positive, but let's hold people to account now about these changes that they've called out that need to happen.
So some positive steps in the right direction. Based on everything that you've seen, what maybe is missing, or what is the one thing that could really make a dramatic shift in obesity care in the next 5-10 years?
I mean, I think we've seen the thing that will make the biggest shift, and that is access to medications, and trying to improve the access to these medications when we have more evidence. However, I think what we talked about earlier about seeing obesity as a treatment pathway, a multifaceted treatment pathway, I think if that's something that could come from the suggestions in the 10-year plan, maybe around all the focus on neighbourhood health, we're going to see neighbourhood health become a much more integrated, structured service that we have in our communities, then having a significant prevention element to that, and lifestyle risk factor element to those neighbourhood health teams. I think it could be a really positive move, because we might then see more kind of, as I say, structured treatment pathways to help people lose weight, so that people trust more that they can raise it as an issue. Healthcare professionals might raise it more because they know there's something they can do about it. There's a solution that they can access, because that is a barrier as a healthcare professional. You don't want to raise something if then you don't really have a solution that you can offer. So if we see more structured treatment pathways that will follow people through, and that might have to be a long time, weight loss doesn't happen overnight, then I think that could be a real breakthrough. So a
good positive first step, putting attention on it. The delivery, as you said, is key, but putting these structured treatment pathways in place and then I guess with more experience, getting people to follow through can start to make a big difference.
Absolutely.
And I guess if we're thinking then about everything that we've talked about, we talked about the impact on the individual, the systemic challenges, some of the new positive steps. For our listeners, what is the one message that you'd like them to really think about and take away from the discussion we've had today?
I think probably from a here and now issue, it's that we are bigger primary care teams now. There are other healthcare professionals within the primary care team that should be able to support you on your weight loss journey. And I kind of encourage people to have the confidence to approach the GP practice and ask about appointments with these other professionals. So I'm not asking to see a GP saying I'm wanting to lose weight. Who can I see? Who's available? And being booked directly in with them. It certainly should be something that's easily available within practices. So I think that would be my message. It's not just about the GP, it's about these. And don't feel fobbed off if they say, well, you're not going to see the GP, you're going to see the social prescriber, because it's actually probably a better option for you when it comes to weight loss.
So I think, Anthony, that's quite a nice call to action to individuals to persevere, also look at the different options as well.
Yeah.
And thank you so much for this really fascinating discussion. I think it's clear there's been quite a lot done, a lot to be done, and lots for us to take on board. So thank you so much for joining us.
You're welcome. Thanks for having me.
And thank you all to our listeners for joining us today. Hope that gives you a bit more information about some of the nuances around obesity care in the primary setting and spark some conversations as well. So join us next time for more on obesity on the Big Picture podcast.